came out, and also a thank you to the Rocky Mountain American College of Sports Medicine. So they are our local ACSM chapter who has funded this event called the Fall Lecture Series. So Dr. Dustin Oranchuk has come here as a part of this lecture series to talk to us about the research that he's been working on the other side of the state. We're lucky that the weather held up today. So a little bit about Dr. Oranchuk's background. He is a certified strength and conditioning specialist with distinction. So a lot of you are taking that advanced strength and conditioning class to get that CSCS certification. He's been through that process. Right now, he's a principal clinical science professional in the muscle morphology, mechanics, and performance laboratory. Didn't think I was going to get that one out. And that's at the University of Colorado at their Anschutz Medical Campus. Originally, he is from Canada, where he earned his bachelor's degree in kinesiology, so a department very similar to this. And that was at the University of Calgary. He then worked with the Canadian Sport Institute before pursuing a master's degree in Colorado at Adams State. And when he was there, he was a strength and conditioning specialist for some NCAA teams. So those of you that are athletes working with our strength coaches, you have a good sense of what they do down in the weight room. He also taught some courses there. He later became the head strength and conditioning coach for the University of Calgary Dinos football team while performing research at that same institution in the Human Performance Lab. He completed his doctoral training all the way on the other side of the planet, Auckland University of Technology, so that's over in New Zealand, and then had a stint at the Victoria University, Melbourne, where he examined muscle architecture, morphology, and performance changes arising from different contraction types. And different contraction types is some of what we're going to hear about tonight. Afterwards, he worked at Acumen Health with various clinical and athletic populations. To date, he has published a number of peer-reviewed research articles, 53, and 21 of those as lead author, so he's been very busy doing research. So he has lots of knowledge to bring to us tonight, which is exciting, and those papers have been highly cited as well. So his aims here are to utilize musculoskeletal imaging and functional testing to improve clinical outcomes, something that's relevant to a lot of your interests. He also examines potential exercise, nutrition, and pharmacological interventions to improve muscle quality and physical performance. So I'm going to get out of the way and let him tell us about the research that he's been doing on the Front Range and all these other places around the world.
Great, thank you.
Thanks.
All right, so hopefully everybody can hear me. If you can't, you just kind of do one of those in the back. But nice little small auditorium, not small, but quaint, cozy auditorium. Anyway, so great introduction. I'm at the University of Colorado Medical Campus, mostly working at the 3MAP lab, that's how we abbreviate it. So there's a couple of different options that I put forward for the talks, and this one seemed to get the most amount of interest, which was actually something I started before joining the University of Colorado, back when I was like trying to get into academia. I was kind of between PhDs and my current role. So we have pushing versus holding, and those will be often abbreviated as HEMA and HEMA, isometric muscle actions, what we know and where to go. So tonight we'll be talking a little bit about my sort of path here, going over the resistance training, background, isometrics as a whole, and then digging into again the pushing versus holding differences. I'll also be presenting some new stuff that hasn't been published yet, but will hopefully get published really soon. So we're kind of on a little bit of the cutting knowledge on this particular topic, and I hope a lot of the athletes in the room will find something interesting, especially if you go into athletic therapy or physical therapy and these types of career pathways. So the next sort of 40-ish minutes probably won't quite be 50, maybe 50 with questions at the end. Again, talk about my background, isometric training. We're going to do a new meta-analysis that's just recently been pre-printed, hasn't been peer-reviewed yet, as well as a randomized controlled or a training trial or study, again, that has not yet been published, so some new stuff. In my background, I will try and blast through most of the stuff that Nate covered, but I am from Calgary, Alberta, Canada. It's basically straight north for about 2.5 days drive. So I've done that a couple of times in my life. I don't want to do too many more times. I've seen Yellowstone enough. But my first job ever was pushing carts around an IKEA, bringing them back into a stall and helping people load furniture into their vehicles and these types of things. And then shortly after that, about 15 or so, I started training at a place called Peak Power Sport Development for trying to get better at playing football. And I became pretty good relationship with the owner, and so he hired me as a part-time role, and mostly I'm stocking fridges and wiping down weights and doing the grunt work, cleaning out spit valves for U2 Max testing and all these types of things. And I found that I enjoyed, tech as far as like timing lights and jump mats and all of these sort of things, and that kind of supported my decision to go and earn an undergraduate in something to do with exercise and kinesiology and these sorts of things. And then shortly after that, as Nate mentioned, I joined the Canadian Sport Institute as a strength and conditioning coach, mostly helping with the alpine ski teams. That's sort of the Canadian equivalent of the United States Olympic Training Center. That was sort of more of a temporary gig, and at one point I ended up coming to the United States for my first stint. This is stint number 2 for me, working with hockey players in Connecticut, and that was a really awesome training facility, some pro guys, some high-level, high-knowledge strength and conditioning coaches, and that was probably one of the first times that I encountered isometric training for sports performance, and really kind of learning about all these different contraction types that hopefully I'll explain a little bit more about today. One of the other temporary coaches in Connecticut was doing his master's degree at Adams State. He was like, hey, we got some graduate assistant work that we're looking for, and we're friends now, so come and still be my friend in Colorado. And I said, okay. So sight unseen, drove across to Little Alamosa of about 10,000 people, which was a big switch for me coming from approximately 1 million people in Calgary. But I had an amazing time, enjoyed Colorado a lot. And I worked with swimming, women's volleyball, and women's basketball. And at some point during my research there, I realized I liked the research thing. I liked working with students. I was teaching a couple of classes. And that was kind of where I made a 90-degree switch from being a practitioner into wanting to be in academia. So that was, sometimes you start a degree program, a master's degree or otherwise, and you come out on the other end with a different trajectory than when you started. So maybe that'll happen to a bunch of you. This video, if it plays, we got a little grant on some force plates. So here I'm just piloting some testing. This is an isometric mid-thigh pull. So I'm essentially doing an isometric deadlift, pushing as hard as I can into those force plates into the ground as a full strength measure. And we got some force time characteristics. And that was part of my master's degree. And another sort of first time experience of doing isometric research in a weight room applied setting. So I thought that was kind of fun to include a video that I took like 10 years ago and just happened to be on a hard drive floating around somewhere. After the master's, I came back to Calgary, trying to find a PhD program. It took a little bit of time until I found a nice scholarship, but was able to work with some great athletes with the football team in the morning, about 100 athletes, which was a great experience, and just try and get some more publications, some more academic experience, build my record for a potential scholarship down the road. I volunteered in this neuromuscular fatigue lab, and again, we're using isometrics as a testing modality. I've got some electrodes to measure muscle activity. I'm about to get shocked in my femoral nerve, so I kick a little bit harder, and I'm going to get some brain stimulation from this machine over here. So I learned a couple of things, but I also realized I don't really want to do research where I'm stimulating and shocking, because it's a little bit painful. People's femoral nerves, and I'm drawing blood and doing all this kind of crazy stuff all at the same time. But again, great experience. And then I got a scholarship to go to Auckland. And there I did some work with ultrasound imaging, looking at muscle tissue and adaptations to different contraction types, as well as a whole bunch of other side projects. So here again, force plates in the middle, barbell, doing some power cleans, looking at force time characteristics, ground reaction forces, sports performance type things as well. After the PhD, Acumen Health, as Nate talked about, I'll talk about that in a moment, but worked at Acumen Health, which was a private physical therapy, sport performance type of business. Surgeons on staff, so surgeries were done, platelet-rich plasma injections, stem cell injections, working with a whole host of health professions, physical therapists, athletic therapists, strength and conditioning coaches, sport coaches as well, including some rodeo, which is really fun. And that's actually a kneecap that's been repaired of a bullfighter, or also used to be called a rodeo clown. And their job is to have like near misses with bulls and jump over them and basically put on a show for a crowd while they're trying to dodge this 1,000-pound plus animal. And this guy got tossed into a gate, hit his knee, and basically shattered the patella, and you're building these things back up. And of course, you need to find different ways on how to load and progress the tissues, get the tendons back in shape, build the muscles back up because they're going to be inactive for a little while. And oftentimes it starts with isometric contractions, doing simple wall sits, stretches, making sure they're just getting the strength and range of motion back, and eventually getting back into jumping once they get strong enough, and then once the range of motion matches from side to side. And I know you can't really read this, but point being is tracking an athlete is really important coming back off of an injury, and isometric assessments are a nice, safe way to do that because you can safely control where they feel pain. If they don't feel pain here, then test them, track them, and progress them there. If they don't feel pain there, that's even better. Test them, track them, progress them there, and so on and so forth. And once you get them relatively strong, then you can move on to dynamic things, maybe eventually jumping and things of that nature. As for the current projects, again, 3MAP is my primary employer, although I do a little bit of teaching on the side as well. And we got a bunch of stuff going on. Another potential talk that I put forth to speak about tonight, which was a little bit less popular, was looking at muscle quality and composition assessments. So use ultrasound imaging, different ways of processing it to tell us not only what's the size of the muscle, but what is inside of the muscle itself. Is it looking like a filet mignon where it's mostly muscle and contractile tissues, or is it like a really raw marbled steak? And you probably don't want a lot of fat in your muscle, so there's different ways that we can analyze these images to track those types of things. Now the main thing that I'll talk about tonight is this pushing versus holding isometrics, and that's a small subtlety, but there's some really interesting findings that I think might lead to further research down the road, whether that's athletic application, rehabilitative application, or perhaps even neurological rehabilitation. Now, as most of you probably know, a lot of you are athletes in this room, I think, resistance training is really important for sport, injury reduction, but also really important for reducing fall risks. And there's just a whole host of benefits that come about with resistance training. Building muscle, losing fat, helps metabolic profiles, reduces risk of like diabetes, a whole host of diseases, cancers, all of these types of things. So we're not going to talk too much about that, but if you're not already doing resistance training, it's probably a great time to start. The best time to start was 20 years ago, the best time is now. As far as getting really specific with resistance training, we have three main contraction types, so concentric, eccentric, and isometric. So just a very brief bit of background. Concentric is when the muscle shortens. Typically this is when you're lifting weights, so doing a bicep curl lifting portion, getting up out of a chair, taking something up off the ground when the muscle is shortened. Eccentric is the other way around, it's an active lengthening. So if you happen to be holding something you couldn't hold for very long, it will eventually pull you into the eccentric muscle contraction or muscle action. Lowering the weight, sitting down in a chair, all of these types of things. Isometric, that's when you're putting in the exact amount of force as the weight that you're holding, so you're just holding it. The muscle might shorten a little bit, but the tendon lengthens, so there's no change in the joint position. In general, there's a whole bunch of little peculiarities that change all the time depending on context, but generally speaking, concentric, or the lifting portion, focusing on that in your training, is going to be most specific to building power. So things like being able to jump high, run fast, these types of things, as well as most of the functions that we do in our day-to-day life. When we climb the stairs, most of that is concentric muscle action. Eccentric tends to be slightly better for hypertrophy, that lengthening under tension, tends to stimulate muscle growth a little bit better than the other muscle actions. We also get some other adaptations like sarcomerogenesis perhaps, where we build a number of sarcomeres inside of the muscle. Isometric, the one in the middle, is perhaps the best for strength building, just pure strength building, because it is the simplest motion and allows us to simply focus on producing muscle force. Relatively low amounts of coordination needed, and we can again focus on just the range of motion that we want, regardless of where the pain might be, or maybe even really specifically what type of sport we do. So if you're an athlete, you never go beyond this range, you just focus in on that range with isometric squats as a hypothetical example. Pain management is also a potential plus, where if you perform a short amount of isometric conditioning before you go into rehab, some people will have a pain reduction, which means they can be more productive in their rehabilitation session. So for an hour or 20 minutes, they might have a little bit less pain than they would if they didn't perform an isometric contraction before going into leg extensions, for example. Now, I added this image and the one on the next slide because it's the oldest thing I could possibly find regarding isometric scientific research. This is a book that was published in 1985, and they talk about a study where they take some muscle fiber tissue this one's from a human heart, actually cardiac muscle, and they're basically putting it under isometric conditions and they're studying it. So that book is 1895, but I actually don't know what year this actual study did. They didn't cite things pretty well back then. So at least 135 or 40 years or something like that. But sort of as I mentioned before, there's no lengthening and there's no shortening, which makes it very safe, very easy to focus on the movement, and you can produce almost or getting close to the amount of maximal forces you could with the high velocity eccentric. Except for the high velocity eccentric, there's a little bit more risk of injury and muscle soreness coming from that. You can imagine if you could regularly squat 300 pounds, if you tried to lower 600 pounds under force, maybe you're going to be safe, but maybe you're not. But that's the type of thing that it would take to get to a force level that high in a muscle. A super maximal lift where potentially you're in a little bit of danger. So that's why isometric testing has become very popular, one of the many reasons. And you can do this with an isokinetic dynamometer. So I know you guys have one in your performance lab. So that's one of the applications is isometric testing. But you can also do concentric and eccentric and isotonic, which is basically like a leg extension machine in a gym. You can also get strain gauges or force transducers where you can push against it with a ton of force. It's not going to move, but you set it up with Bluetooth or something to a tablet, and it can probably tell you just how strong you are with that type of movement. And you can set it up in a bunch of different ways. So this is almost like that mid-thigh pull I showed in the video before. Instead of standing on force plates, you can have this really portable little device, hook it up with some chains and a handle, and you get something like that. You get that isometric deadlift, but now it's in something you hold in the palm of your hand. You don't have to, haul these force plates around, and you can take it on site with athletes and teams or in a physical therapy clinic or something like that, and it doesn't take up a big amount of floor space. There's also some pretty cool new devices. So this is a force frame, it's called, and this is actually the athlete who had the shattered patella a couple of slides back. And we have this device, and depending on how you rotate this part and how you lift and lower, and whether you put the athlete in a seat or you're lying on their back or you're lying on their side, or any of these other things, you can test internal rotation, external rotation, up, down by the side, knee extensions, hip extensions, all of these types of things. Anything you could possibly think of, you can rotate this thing around and get some good testing done. So isometric testing, as I just mentioned, really popular, very widespread. Even if it's just pushing against a hand in a clinic, that's a form of isometric testing. Training, however, is a little bit less known. There's way more variables involved when you're talking about these types of things. One of the older books is called Super Training. That's from an old Soviet guy from like the 1970s Soviet Union team. And he wrote a book with a guy named Mel Sif when he migrated to the United States. But a little bit more recently, you have this book called Triphasic Training. I think that came out in 2012, so relatively new. And it was one of the first books that actually recommended having an eccentric phase, an isometric phase, and then a concentric phase. So you do a couple of weeks of one, then the other, then the other. I don't necessarily recommend that myself, but it was an interesting idea, and it kind of shows the evolution of how things have been moving. Now, one of the topics of my PhD resulted in this paper, so that was my most cited thing so far, and that was a systematic review looking at different variables involved in isometric strength training. Now, I'll walk through a couple of slides here to get the idea, but on the bottom end, we have joint angle trained, and on the y-axis, we have muscle size. So this is the change in muscle size over a certain number of weeks, and we have each one of these dots is a different study. And we can see a subtle, but a little bit of a curve there. So if I were to draw a line of best fit, we see a trend where the longer the muscle and or length, or the larger the joint angle, the more muscle size is built. So if you're going to perform an isometric at this joint angle versus this joint angle, the second one will typically be better for building muscle size. Bigger stretch. We have another analysis. We look at training intensity. So this is pushing as hard as you possibly can, and this is pushing much less hard than you possibly can. And again, change in size. This relationship is a little bit less clear, and definitely no statistical difference there. So for hypertrophy, the amount of contraction intensity doesn't seem to matter that much as long as the work is the same. And the last one I'll show is, again, training intensity, how hard you're working, what percent of your max effort you're putting in versus strength. And here we see a subtle relationship, but a little bit positive again, where the harder you push, the more strength you gain. Which makes sense, right? If you want to get strong, you have to either lift heavy weights or at least put a lot of intensity into whatever activity you're doing. And all of those findings have been further supported by research on dynamics. So not just isometric, but lifting weights up and down. All of those things ring true for all the other types of contractions. Now we have a little bit of a background on isometric training and testing for that matter. We get into sort of like the main stuff, which is pushing versus holding. So they're both isometric muscle actions where the joint is not moving, or at least very minimally, and the length of the muscle tendon unit remain the same for the entire time. Now the first study that really made me like think about this was this one. And that happened in 2017. And as you'll see in a couple of slides, the oldest study I've been able to find that directly compared pushing and holding isometrics was 1995. And there's been a whole bunch in the late 90s and early 2000s. And still, the newest one I think was either earlier this year or late last year. But it only really like caught people's attention here. Part of that might be because 2017, now you've got like Instagram and you got Facebook and Twitter and all that kind of stuff. But the other thing was that this one was really good in the title, right? You've got a little bit of a catchy title and it's explicitly telling you what they're doing. Whereas when I look back at the studies from like 1995, 2003, 2001, the titles are frankly really bad. Okay? You have no idea what they're doing. They're like, we're gonna examine these two tasks, and they don't actually tell you what's going on. So that probably hurt their efforts in getting people to read and cite their work. So a little lesson there. If you're going to publish something, or write a book, or do a Facebook post, be explicit of what you're actually talking about. Regardless, that 2017 paper from some German researchers, they hook people up to this type of a setup. So they have some electrodes going on in the prime mover, which is the tricep, as well as the supporting muscles. So they have some muscles in the upper back, as well as some abdominal muscles. And they have this piston attached to a strain gauge, and depending on the day, so people would perform both tasks just on different days, they would either be pushing into this piston that was set to not move at all. So it was set to just an isometric setting, and they would push in with a certain percentage of their max. So again, you can imagine like pushing into that with 30 pounds of pressure. Okay. Then on the other day, that piston would push against them with 30 pounds of pressure, and they resisted movement. Okay, so instead of pushing into something that cannot move, they are resisting the exact same amount of force trying to move them. Same idea, just to put the point all the way forward. If you're holding a 40-pound dumbbell versus putting 40 pounds of force into a strain gauge attached to a chain. That's essentially what's going on in all of the studies that I'll kind of mention in the next couple of minutes. Had some really fancy, crazy graphs that are really hard to decipher, but basically what their main findings were was that when you're pushing against something that is immovable, the electrical activity in the prime mover muscle is higher than when you're resisting pushing, but when you're resisting or holding, the accessory muscles, the muscles that are stabilizing the torso, the muscles that are stabilizing the shoulder, perhaps the muscles stabilizing the elbow have a little bit more activity. And the brain activity is also a little bit different, but that's a little bit more difficult to communicate because I'm not a neuroscientist. Now again, as I mentioned, I kind of started this next project when I was in Calgary, working in strength conditioning, having a good time, but still wanting to get back into research and academia. So I said, let's put a team together and I'll make it sort of a side project of mine. And let's go way up to the quality of evidence hierarchy at the top, which is meta-analyses. So for those of you who don't know what a meta-analyses are, we take all the data we can find that fits our specific criteria that would help us answer our question, and we find them in the databases, extract that data, we try and pool as much of that data together. So we're taking data from multiple studies and we're adding it all together, kind of weighting it in a specific way. So instead of running a study where we maybe get 20, 30 people, we're in some cases able to get comparisons with several hundred participants that would be essentially logistically impossible to do in a single study at one location, no matter what kind of grant money you're looking at. Trying to gather 300 participants might take you years and years of effort. So this is the first one. This is a QR code if you happen to be interested. It's a preprint, it's not peer reviewed, but we finished it a couple of days ago. So that's brand new. And you can see just some examples of some of the comparisons that are included in that meta-analysis. We have knee extensions. So again, we have that strain gauge on the ground versus a weight that's been suspended from the ankle. Same idea, we've got elbow flexors, all the way down to the little muscles in between your hand bones that abduct and adduct fingers. Ankle flexors, there's a couple studies that look at the back extensor muscles, so sort of the glute ham, lower back musculature as well. We found almost 7,000 papers that fit our search terms, but once we distilled everything out, we were left with 54 studies that directly compared pushing and holding isometrics in the same participants that were humans, not mice, not single muscle fibers, humans. I'm not going to talk about all this, just some study characteristics. So again, 54, and that total 586 participants. Again, something where if you were to try and get that in a single lab setting would be an astronomical task. All of them were single joint, which I'll get back to as far as applications in a handful more slides. So all of them were like elbow, a finger joint, a knee joint, an ankle joint. So that kind of limits a few things that we're talking about. And one big limitation that I'll just kind of get out of the way is that the contraction intensity was only about 35% on average. Some studies were upwards of 80%, so great, but for anybody in this room, you probably know that lifting weight at 35% of your max is usually not enough to elicit any sort of adaptation. So just kind of keep that in mind. The other thing is that all of these studies were acute studies, meaning that they brought them into the lab a couple of times. They were not training studies. They were not trying to get adaptations out of them. Instead, more trying to learn about the contraction types themselves and what sort of acute cross-sectional effects they have on the brain or the electrical activity of a muscle or blood flow or these types of things. First thing you do, maybe not first, but one of the first things you do in a meta-analysis is make sure that the studies you're putting and pooling all together are not bad studies. There are such things as bad studies where the data is not very good, and you just don't want to muddy the waters by saying we included all these things, and the peer reviewer comes back and says, yeah, but that study was really not so great. Luckily, all of our studies had a relatively low risk of bias, and they were also relatively high quality. Some of the only issues were like effect size reporting and confidence intervals, which only really become popular in the last 20 years or so. And for anybody again who doesn't know, you have your p-values, which basically tells you whether an effect is statistically significant. Typically that means that it's relatively consistent. We're sure that that effect exists. But an effect size is more like how big is that effect? And you can try and think about that as if you have a football team, you have 80 athletes, if every single athlete puts 2 pounds on their back squat, that might be a statistically significant result, but 2 pounds is not a lot, so you might not really care about that result. And that might be an example of a significant p-value, but a negligible or trivial effect size. So kind of both of them play a role. The reason I bring up effect size is because that's usually how meta-analysis is interpreted. This is not from our meta-analysis, but it's a nice picture just to make sure we are all understanding what's on the next slide. This is a forest plot, and it's typically the main way that meta-analysis results are presented. So on the left side, you have all the individual studies, and you have whatever sort of an effect you're looking at. This could be muscle size, this could be blood sugar, it could be anything like that. And then depending on how large these squares are, that's going to represent the sample size of each study. So the one by Chu here might hypothetically have a sample size of 100, and Jones might have a sample size of 10. So that square is 1/10 the size of Chu. And then you would basically average them all with the weight of their sample size into your total overall effect. So, the meta-analysis had a whole bunch of comparisons. The first category that I'll present is mechanical performance, biomechanics, things like that. And the first one, and where I'll talk you through all this, is time to task failure. So basically, if we're using that example like holding a bicep curl, a dumbbell, how long can you hold that weight there versus how long can you put that same amount of force into the immovable strain gauge? When do you stop being able to hold and that weight gets dropped? Or when does that line on the screen from the strain gauge say you're not putting a 40-pound force in anymore? You become tired or fatigued beyond being able to maintain anymore. So what we see is an effect size of 0.74, which is pretty big, that's pretty noticeable, in favor of pushing. That means that almost exclusively, people were able to push into the immovable object substantially longer than they could hold the same amount of force, okay? Almost exclusively. Now, if you're really paying attention, I wouldn't blame you if you're not seeing it, but you might notice this little square here. These two studies, only two studies, mind you, are completely on the opposite end. They have a very, very large effect size, 2.63, which is, it's like very obvious. You don't need technology. You don't even need a stopwatch. You can just watch them perform it, and you can visually, put it all together that they're the opposite direction. And those are the trunk extensor muscles, basically the muscles of your back. And this is kind of interesting because the muscles of your knee extensors and your ankle flexors, those are more propulsive muscles, right? That you use to run and jump and get out of your chair. Whereas the trunk extensor muscles are kind of always holding you upright all day, every day, whether you're sitting in a chair without a back, or you're walking, or you're playing sports, or you're lifting weights. If you're doing a back squat in the gym, your legs are propulsing, and your lower back is basically just keeping you from completely tipping over. So those muscles have been habitualized to holding isometric contractions, which again kind of explains why they're completely on the other side of the spectrum from all the other muscles that were included. We also performed what are called meta-regressions. So again, the bigger bubbles have the larger sample sizes, and you can see we have intensity on this x-axis and the size of the appendicular muscle groups. So we took out back extensors because they totally threw off everything. And the main thing here is that those lines are very flat. And what that tells us is that this effect that we see here is not affected by contraction intensity or the size of your muscle groups. So So whether the researchers had people put in 80% of their max effort or 20% of their max effort, the general effect was the same. That didn't affect it. It also didn't affect it whether you were looking at the finger adductors or the big muscles of the thigh. The effect was the same. The next thing was RPE, or ratings of perceived exertion, which is how difficult does it feel. So you typically will ask this on a scale of 1 to 10. Sometimes it would be a scale of 1 to 24, although that's more cardiovascular research. Well, 1 to 20, not 24. Now, we can see not really much of anything going on, except for maybe at 50%. Okay, so 0% of time to task failure and 100%, whoops, are all really small, but that 50% of time to task failure is kind of getting up to something that most researchers would start paying attention to anyway. But we also need to remember that 50% of time to task failure for holding is less time than 50% of time to task failure for pushing. You can push longer than you can hold. So we had to look at that in a little bit of a different way, and we see the rate of increase, which is typically a lot faster for holding. So it started to feel harder much quicker. Probably not too surprising. If you fail faster, it probably starts to feel harder faster. The next sort of category of results was cardiovascular and metabolic effects. So here we have heart rate. Not really anything in heart rate. So again, small to trivial effect sizes in some cases, like literally nothing. No differences at all. Again, the rate is going to be a little different. We'll see that in another slide. And then the other thing we were able to use with meta-analysis was mean arterial pressure. So basically just blood pressure, just averaging systolic and diastolic blood pressure together. And once again, almost nothing, nothing that anybody's really going to pay attention to. But again, when we look at the rate of increase, we can see heart rate and blood pressure increase faster during holding. Some of that is going to go back to a few things that I talked about on a couple of slides before, so I'll loop back into explaining why. But the last couple things with the metabolic variables was there's no difference in tissue oxygenation, but a couple of studies, not many, looked at glucose uptake in multiple muscles, right? So basically you're using a CT scan to look at how fast muscles are eating up glucose or blood sugar to fuel themselves. And what we can see is this study ended up calling it position tasks, position means holding, versus force tasks means pushing. Okay? So the holding, you can see a whole bunch more color and a little bit more muscle. So this kind of loops back to that first study with the piston and the tricep, where the muscles around the prime mover are more active. So in this case, they're eating up more glucose. In the other study, there's more electrical activity going on in those supporting muscles. So that kind of explains that. And if those muscles are more active and they're eating up more glucose, that might have that effect that we're looking at with the heart rate and blood pressure, right? When muscles are active, heart rate goes up faster. When muscles are active, blood pressure goes up faster, as opposed to if you just have one single muscle working hard. The last sort of category was neurological variables, and this one we don't have any meta-analysis results, but I can talk to you about some general trends that we saw. The reason there are no metabolic or meta-analysis results is that the methods are too vast. So I'm definitely not going to read off the slide too much, but this just kind of gives you an idea of how impossible it is to pull all of these things together and have them mean anything. Okay, it's like trying to take every athlete from every sport and make a general conclusion about one sport. Okay, you probably just don't want to do it. It's not a good use of your time, and it's not particularly robust. So 41 studies used surface electromyography or electrodes to measure muscle activity. A couple used needle EMG, which is it's a cool technique. Basically, you have this really fine wire, and you insert it past the skin, past the fat, past the fascia into the muscle to measure activity that way. A bunch of other ways of looking at muscle activity, and then electroencephalography is maybe you've seen this on like a commercial, like a Gatorade commercial or something, and they put like a hat on, they've got electrodes all around the skull, but they're measuring electrical activity inside of the brain. There's also a bunch of studies that had peripheral nerve stimulation, that same thing I told you about before, where you're pushing and you like get shocked if you push a little bit harder. There's mechanical stimulation, transcranial magnetic, etc. And all of these things, especially the EMG, you can process those in a whole bunch of different ways and get so many different results out of it. There are also several studies that use different things like different core temperatures, residual force enhancement, and experimental joint pain, which that one is quite interesting, I think. But point being, you can't add all these things together and get a cohesive story. But as far as the electrical activity, the brain activity, the main thing is that they are definitely different, and that co-activation, so all the other supporting muscles, much more active in the holding versus pushing, whereas the prime mover muscles are more active in pushing. Just what I said a few times before. The interesting one that I hope is more looked at in the future was there was 2 studies that looked at something called experimental joint pain. And that's a really interesting technique. So what the researchers will do is they'll take a saline solution, probably some other things in there depending on what exactly effect they're trying to get, and they will inject that, in this case, into the knee. You can do an elbow or fingers or whatever, and what it does is for roughly 2 hours or so, the joint is painful. So you're essentially simulating arthritis or tendinitis or some other sort of joint issue. So it's a way of studying people who are injured without actually having to recruit people who are injured. Because everybody's injured differently, right? It's really hard to get 10 people together who all have the same degree of osteoarthritis and all have the same degree of clinical indication in terms of pain and inability to walk upstairs and all that kind of stuff. So you can a little bit more easily match, and you also don't have to try and find people at a clinic to come into your lab. The main thing here, again, I'm not a neurophysiologist, but one of the people on the team is, but basically brain activity and muscle activity were less affected by the artificial limb pain when they were performing holding. So small samples, all that kind of stuff, but perhaps holding isometrics are better tolerated by people who are currently in pain, and that might make them a better recommendation for early rehabilitation. Now, that's a meta-analysis. I think it's really cool. It's probably the longest, most comprehensive thing I've ever put together, so I'm particularly proud of it. But something a little bit more exciting, I hope, is an actual randomized control trial or a training intervention. So one of the people who I invited to help with the meta-analyses, because they're also kind of an expert in similar things, and strength and conditioning background and all that, his name is Danny, and he works at the Singapore Institute of Sport, and that's where this study was done. So it was within participant design, so 10 people participated, but we had 20 limbs at our disposal, basically. And there's positives and negatives to that kind of a study design. I'll mention a few of them in a minute. But we got this isokinetic dynamometer. It's actually the exact same brand you guys have here. And depending on the limb, whether it was right or left, that would either be set to not move at all, be impossible to move. And you got a forced time tracing that says, okay, well, keep your line here, and we're going to do 4 sets of 30 seconds at 70% or something like that, versus loading it as though it were a knee extension in a weight room in a rec center, for example, and saying, okay, we're going to load this with the exact same thing. We want you to be on the screen with the other leg, but it's going to try and push you, and you resist as best you can for the same amount of time and the same load, same number of sets, same number of reps, and rest, and all that kind of stuff. There's also a mixed sex design, so 5 males, 5 females, and they were all just like recreational tennis players, badminton players, those types of things. Before and after the intervention, we used ultrasound to image muscles and tendons. So we get a muscle thickness of all 4 of the quadricep muscles, which is kind of important, which I'll get to in a minute, but it's important that we get more than just one. Muscle architecture, which is essentially pennation angle, is the angle that the muscle cells or muscle fascicles will insert onto the aponeuroses, so this angle right here. That has some potential application for how fast a muscle can contract. And then fascicle length is the length of each one of those lines that you see. Typically speaking, the longer the fascicle, the more sarcomeres. All the sarcomeres shorten at once, so the longer the fascicle, the faster the entire muscle can contract, potentially. There's a whole bunch of other things that are in play there. Patellar tendon thickness was also measured, and also importantly, we measured strength concentrically, eccentrically, and isometrically to see sort of that specificity of training. Now, the main results are a little bit unexciting when you look at them in NOVA, because even though each group, so the pushing limb and the holding limb, they all improved from the start of the study to the end of the study. So all the muscles grew, all the strength went up, all that kind of stuff. The difference between the legs was not significant based on an ANOVA. ANOVA is a really nice and strong statistical technique. It makes type 2 errors or false positives really rare, so it's not like you're going to say something did happen when it didn't. But we're going to try and get more sample size to try and suss that out. Not surprising, right? Shouldn't be that surprising because the two interventions are so similar. So I don't think the devil is probably going to go back to looking at those effect sizes that I mentioned before, because consistency, as you'll see, is all over the place. So these are some table or figures that show the results, and this is strength. So on the left side, we have concentric strength, the strength when the muscle is shortening. This is eccentric strength when the muscle is lengthening. And this is isometric strength when it stays the same. Each of these data points is an individual person's leg. And we're gonna have to fix that figure. I was hoping that the diamonds were females and the circles were males. That's actually not the case. So it's good that I just found that before I did it. Either way, the cool thing, I think, is that even if it's not statistically significant with any one of these three, the pushing improved strength a little bit more regardless of how we tested it. On the other hand, muscle thickness or hypertrophy, once again, somewhat minimal results in terms of statistical difference, but the holding limb grew more in all of the quadricep muscles. And when we actually do just a simple paralyzed t-test, the rectus femoris, that's the muscle that goes down the center of your leg, this is actually statistically significant with a slightly less robust test. And the effect size there is moderate, which is something that in practical terms might mean something. Now, why the rectus femoris and not the rest of the quadricep muscles? I think that has to do with the fact that the rectus femoris is the only one that crosses both the knee and the hip. That means that the rectus femoris during knee extensions is a prime mover, but it's also a stabilizer. And as I mentioned before, the stabilizers are typically more active than the prime movers. So if I were to do the study again, I would measure thickness near the distal portion and thickness near the proximal portion, not just in the middle. So that's a lesson learned, I suppose. So either way, though, it does seem that holding is better for muscle growth and pushing is better for strength. Now, tendon thickness, also moderate effect size, but really inconsistent. If this person didn't exist, that probably wouldn't exist either. So keep that in mind. Fascicle length, also not big differences. Pination angle, or that's fascicle, pination angle also, again, really noisy, probably no big difference there. To me, that was somewhat unsurprising. Usually it takes drastically different interventions to really change muscle architecture. But in general, the cool thing, I think, is that the randomized control trials, or that training study, support the meta-analysis results. It's not like we saw one thing with these acute studies and then the complete opposite training, like, well, what the heck happened? They're supportive. So the pushing, better for strength and performance, possibly because the muscle that we're actually using in the testing has a higher activity when we're doing those pushing contractions. So neurologically, the development is going to be more specific to pushing with that muscle later on down the road. Same thing with holding, morphological adaptations, so rehabilitation, muscle growth. And this is because muscle growth is triggered by many things. The number one thing is mechanical tension, so basically how much tension is going through your muscle. But in that training study, the mechanical tension should be the same because it's pushing down with the same amount of force that you're pushing up with, so the tension is the same. But another factor that contributes to muscle growth is actually our metabolic and hormonal factors. So when we look back at that study that had the glucose uptake, for example, you're having a more metabolic environment. Glucose is getting eaten up faster, blood pressure is higher, all of these types of things. There might be different hormones going on. It's like blood flow restriction. Okay? So when you have blood flow restriction and you cut blood flow off your muscle, even walking becomes hypertrophic. If you have people who are untrained enough, you put a blood flow restriction cuff and you walk them on a treadmill and their quads grow more than it would be if they were walking without that, because you're creating this metabolic environment that the body's going to try and adapt to later by producing more muscle fibers. Once again, smallish sample size. The intra-limb study design, where one leg does one thing, one leg does the other, is great because it effectively lets you double your sample size. But it's a little, and also you don't have to control like dietary factors. So a lot of times in a training study, you want to make sure that everybody in one group, gets the same amount of relative protein as everybody in the other group, and all of these types of things. Otherwise, one group might have just got better because they were better at eating protein, or they took creatine or something like that. But when you have the same person, now you don't have to worry about that. It's not like they're going to have more of their protein going to the right leg than the left leg. But neurologically, there's some carryover effect. And maybe you've read about this before too, where if like your right leg's in a splint, it probably actually makes sense to do activity on your left leg because your brain still is practiced at moving your legs, even if it's just one leg. So you'll recover faster when you get that splint off if you're active with your non-splinted leg. But again, I'm excited, I'm happy because the meta-analyses results kind of are supported by the randomized control trial results. And at the end of the day, pushing seems to be best for maximal strength, sports performance, and holding seems to be better for building some muscle, probably early rehabilitation type work. Maybe tendon thickness, although again, it seemed like one or two participants just kind of skewed the data a little bit. So a little too early to tell on that. But again, if we added that patellotendon adaptation with the experimental joint pain, again, maybe there's something cool there. As for future directions, there's some cool ones. So these are all images from some of my collaborators against Singapore Institute of Sport. This one was at the New South Wales Institute of Sport in Sydney, in Australia. But one thing I mentioned before, all of those studies, including the training study, were single joint muscle actions. So multi-joint muscle actions, squats, hip extensions, bench presses, pull-ups, these types of things, holding the pull-up, etc. Higher intensities. Our training study was relatively good intensity, about 70%, but all of those other ones with the studies, most of them were more in the range of like 20 to 50%, relatively low. And then clinical, adaptive populations, these types of things. There's also an interesting thing here as far as using holding isometrics or adaptive force as a testing consideration. So all of those testing things I showed you before, where we're looking at strain gauges, that was pushing against something immovable. Those are pushing contractions. Most of the time when you have non-contact injuries, it's almost never from the muscle trying to shorten. Okay? If you look at if you pay attention to football, Aaron Rodgers tore his Achilles in third play of the first game or something like that last season. And if you watch that injury and almost all of the injuries that you can see in slow motion on a football field or otherwise, they're resisting an eccentric contraction. They're getting tackled, they're getting pushed back, and then something pops. It's almost never where they're just running and that muscle is shortening. In this example, this is the late swing phase, and muscle like hamstring tears usually occur when the person is running and the muscle fails at stopping their shank from moving beyond where they want it to go. So they fail in that holding contraction, muscle tears or tendon tears, or get some sort of a strain injury. So while isometric testing is really cool, maybe one of the ways we can improve rehabilitation and testing and tracking of like hamstring tears, for example, would be to use a strain gauge and literally pull against that strain gauge until they fail and see what kind of force they can withstand before their joint I think that's a really cool potential application. And there's a lot of talk around like hamstring or like Australian football and things like that. They put all of this effort into trying to fix it with very little results. And I don't think I have the silver bullet, but maybe there's something intriguing for people to look at in that way. Some other grant opportunities. So if this is something that really motivates you, maybe you can talk to Nate and me, and we can see what we can maybe do as far as some interesting grants to the NSCA. And then I want to basically at the end of here, so just some quick shout outs to Andre Nelson. He was one of my PhD supervisors and a big part on this project. He's at BU in Australia. Danny Lum, who has a position at Latrobe, but most of his time is spent at the Singapore Institute of Sport. And then his supervisors, Xiao Shen and Xiao Kong from the Nanyang Technological University in Singapore. And then we got Alex Matera, New South Wales Institute of Sport. And then finally, those two German authors, I invited them to help me out, and they were a massive help, especially on the neurophysiology side of things. And they're at the University of Potsdam. So, if there are questions, I will take them. My last piece of advice is typically, instead of just putting questions up on the board, and if there's no questions, everybody's really bored, at least put something on the screen that's interesting or pleasant to look at. So I decided to include the animals in my life. So I live with the 3 cats, including this one who's about 21 years old, so older than a lot of you in this room. And this is my girlfriend's dog, Quincy, who is a very good boy. So I'll go ahead and take any questions if there happen to be. Thank you.
So, when you're doing the whole isometric muscle action, how fast are you introducing that force? Is that kind of something that went into play?
Yes, and that's a very, that's a hard one. It's a hard one to answer what other people have done. Because that's a particular part of the methods that is very difficult to describe. Okay? In the study, the one at the Singapore Institute of Sport, for example, and I used something similar in my PhD, but it didn't actually fit into that topic because it was not a purely isometric contraction, but the beginning was. And that one is, again, difficult to describe. In almost all the studies, it's not described like at all. At all. In my experience, you help the person up, and then you slowly release it on them. And you're using your hands, your literal hands. So it's not exactly all that scientific, but I think it makes very little difference for these studies because that portion is like 1 second versus them holding it for 30, 40 seconds, 60 seconds at a time. So it makes up a really small portion. But I think it could matter, especially when you talk about that idea I had as far as like testing with a holding isometric. The rate of increase on force would have to be controlled very carefully. Otherwise, the results are going to be very difficult. So I'm not sure if I have a good answer for what should be done, but I know somebody needs to come up with a good way to actually control it. And that's kind of the benefit of the pushing isometric thing is you can just say push as hard as you can or follow this curve on a screen or something. It's much easier to control. But, good question. Maybe.
So say you wanted to use one of the tests to like evaluate a patient and then take the rehab protocol and evaluate again. Are you just looking at, like say you were doing a pushing task with the knee flexion, would you just be looking at a change in force output? And like so theoretically you take the rehab protocol and it improves? And is there a certain amount of improvement that is associated with any kind of clinical outcome? So like, okay, their isometric force improved by 50% or 50 kilograms, and that's associated with less falling or better balance. Like how a lot of our students are either training to be clinicians or will be in the future. Is there ways that has been incorporated in that setting?
So
Or in a sports setting, strength and conditioning.
So that's a great question again, and somewhat of a difficult one to ask because I don't think there's all that much information out there on like, there's normative data for populations, so you can go online and if you can find a study that fits your population really well, then you can kind of go through this. So I was talking to Nate and somebody else about like the rodeo research we did, so we got 40 rodeo athletes and we put together a normative data set. Well, how strong are most rodeo athletes at this exercise with their bull riders versus bareback riders versus whatever, and how strong are the ones who are like competing at world championships versus local champions and things like that. So that's a specific one. There's quite a bit of data out there on like arthritis and certain age groups and things like that. So that normative data is something you can hopefully find in your academic journals online and try and meet that standard and hopefully exceed that standard with the REAP. If you can't seem to find a paper like that, then probably the best course of action is to use the healthy leg as the benchmark. It's not necessarily perfect because maybe the healthy leg is weak too. It just might be less weak. But at least if you close that gap between the healthy and non-healthy leg, then you can kind of still build them up all together at the same time. As far as whether these things actually relate to injury reduction, that's also actually not as clear as you might think. So even meta-analyses on like the Nordic hamstring exercise, you guys might know, some of them have shown that that does reduce hamstring tears, for example. And then there was another group who analyzed the data differently, and that shows that Nordic hamstring do not change hamstring tear risks. So that's the really hard thing about injury studies, and why like I think that experimental joint pain stuff is really cool. Is it just there's so many variables that make answering that question hard. If you want to study concussions, you test a bunch of people, and then you almost have to hope that a bunch of people get concussions, which is not a nice thing to hope for. But if you test 300, maybe you get a sample size of 20 in like 5 years' time or something like that. So tough stuff to do with injuries. Yes.
How do you determine the amount of weight you use on the holding isometric contractions if you're doing like a back squat or hip extension or one of those ones where you load the barbell?
Yeah. That's another good one. I would say, in general, isometric training recommendations should be pretty close to non-isometric training recommendations. Okay, so what I mean by that is that if we have all this evidence, first-hand experience, right, so scientific or clinical or what works for you individually as a person, so a general application for muscle hypertrophy training would be like 3 or 4 sets of 8 to 12 at 65 to 75% of maximal contraction or whatever max weight you can lift. Probably if your goal is to add additional hypertrophy to a isometric contraction, you'd probably be wanting to aim in the range of, again, that 65 to 75%. If 3 sets or if a set of 8 to 10 takes you 45 seconds of the muscle being under tension, concentric and eccentric, then probably a good place to start, 70% of your max effort and holding again for 45 to 55 seconds. So that's kind of why I added those slides. Well, this was the isometric stuff, but all of these studies support that with the dynamic things. So I don't think the application is completely night and day difference. Yes.
What would be, I suppose, the practical benefit to using isometric training in, let's say, like outside of an injury rehab, like sort of see it for that particular realm where we're taking people who have painful ranges of motion and then just working them as hard as we can with that, in that a pain-free range of motion in a way that's easy, like feels good for them, right? But then with healthy athletes who can do a full, typical isotonic, like full eccentric, concentric range of motion, is there a benefit to using isometrics outside of that, in replacement of, in addition to, like, what does that look like from that standpoint?
Great. And actually, I gave the same talk last week at App State, and there was another question that was somewhat similar, so hopefully I'm a little bit prepared for that one. But yeah, so isometrics for the most part, when I'm talking to people as a strength coach and a researcher who's like, I think that would be cool to study, like, how would I apply this? For the most part, in most situations, weekend warriors, etc., I generally say, keep it pretty simple, you know, back squat your normal way, eccentric, concentric, all of these types of things. If you're not hurt, most contexts, just train without worrying too much about isometrics. However, I think there are some interesting things that you can do with isometrics in different contexts. One of which would be in-season training for certain athletes. So by the time the season just kind of rolls on for football or volleyball or whatever, talking about your training schedule, you're taking a lot of hits on a football field, you're probably sore, you're probably beat up. One of the other benefits of isometric training is that you can put out a lot of force, you get a lot of neural drive from your brain to your muscles, but isometric training, unless done to like really extremes, almost always causes less muscle soreness than isotonic or especially eccentric training. So it might be a way where if players are complaining of having really sore muscles, but you still want to try and keep them as strong as they can for as long as they can in the season. Adding some isometric deadlifts, some isometric squats, and some pins or something like that might be a nice way of loading the muscles, loading the tendons, keeping them strong, keeping the brain firing those muscles, control it. So if you're only going to push for like 3 sets of 10 seconds or 2 sets of 10 seconds or something like that, and that might help them maintain strength for the whole season without causing more wear and tear on their joints and on their muscles. So I think that's probably the main way I would apply it.
Any final question? You're just burning to ask. Mark?
What would you say like an ideal time, like for full isometric is? It's too long, it's too short.
So, kind of again, it depends on your training goal. So same idea as like with the hypertrophy. If you're trying to use it to improve muscle growth at the rehab setting early on, probably something that if you can hold it for like 5 minutes, it's probably too light. But if you're trying to build strength, then maybe 10 seconds is the limit. If you can only hold for 10 seconds and it's too heavy, then that might be your best bet for actually building strength. So it just depends on your goal. And matching the general recommendations for training or non-isometric training, I should say. Yes.
So what about isometric training in the rehab setting for just muscle activation? So after knee replacements, after any knee surgeries at all, that quad doesn't know how to fire anymore. And right now, best practice is quad sets all day long. Most people can't find their quad. So do you think if it's not painful and we're still following protocols, would isometrics kind of be the best in that setting?
I'll preface this by saying I'm not a physical therapist or an athletic therapist or a medical doctor. It's a little bit hard for me to say. But even like when you say quad sets, what do you mean by that?
So they're literally just laying on their back, put a towel under your knee, and it's pushed down into the towel after your quad. And most people just squeeze their butt.
Yes, they're pulling with their hamstring or
Yeah.
something like that. Yeah, so I think at some point, and this is again where you're trying to get the terminal knee extension in that phase. So that's an interesting one too. Is it better to try and have them cue them by pushing into a towel, or is it better to like hang a 2-pound weight off their ankle off the edge of a table? I'm visualizing that. That would be actually kind of interesting to see. Put some electrodes on there and see if the EMG is picking up a little more activity in one exercise versus the other. I don't know. I'd say if they're able to go past that first range of motion, if you're just after quad activation, yeah, going into more flexion and pushing against, you could even take like a leg extension or your hand if they're really weak. Put it at something that you know they can't move and just tell them, hey, push with like 2 out of 10 effort. A lot of times RPE is not a bad way to go if you don't have technology as well. But again, usually that longer stretch of the muscle will have it activate
Dr. Arndt, have one more.